Hi friends, Red Arnold here. Well, it's finally at our doorstep. Some of us tried to tell you, but were dismissed as malcontents. Most of us in America are now coming to realize the truth in that Obamacare is a failed policy. But before you jump to the conclusion that this is some politically motivated bludgeon fest, keep in mind that all of us are going to need health care sometime in our lives. I've been to funerals where they said, "He never took a sick day," but I have yet to attend a funeral where they said, "He never once went to the doctor." The healthcare industry is broken, and if we don't do something about it here soon, it will be the next bubble to burst. Mark my words. This affects all of us. Black, white, tall, short, young, old, man, woman, child, everybody. But in order to begin to address this point, we have to look at why Obamacare exists in the first place. Obamacare exists because things are so messed up that the American people are literally screaming for something to be done. But as it's coming to pass, Obamacare is not the answer. It never was. So what is? For those of you who wanted socialized medicine to fit a socialized society, this presentation is not for you. If you want that, move to Europe and tell me how great it is when you've moved past the sniffles and need open heart surgery or a knee replacement. This presentation is for people who want a solution to healthcare. This is for the people who want to receive the best medical treatment the world has to offer and not have to go broke in order to have it. So what is this about? What do we do about it? Where is this Savior who is going to put the world on his shoulders and carry it to salvation? Well, it's Atlas. Yes, Atlas. Like the Greek god who carried the world on his shoulders. And the Atlas I'm talking about is atlas.md. This is nothing to shrug your shoulders at. But before you think that this is a sales pitch, let me just say that there were many people who attempted the first flight, the first modem ping, the first phone call. Heck, Alexander Graham Bell beat Elijah Gray to the patent office by a mere matter of hours on the same day. Lots of people have had A and B, A and D, D and E, etc., but it's the first person to have A, B, C, D, and E together, chronologically, cohesively, and brings it to the public who gets the credit. So even though I will tell you about this system, it is atlas.md who made this possible. What if I told you that there was a little-known loophole in Obamacare that allowed you to see your family doctor without the constraints of an insurance company? What if I told you that you don't need to annotate any ICD codes ever again? What if I told you that you could have 24-hour access to your PCP, your primary care physician, without having to worry about coverage, without copays, without having to succumb to ER visits for late-night medical situations like asthma, broken bones, stitches, ear and urinary tract infections, or strep throat? I know what you're thinking. You're thinking it right now. You're thinking, Red, you're out of your mind. I know you're thinking it because I thought it too. And even I had a similar idea to what I'm about to tell you. Even I took convincing. Not much, but it took convincing. Even I was not aware of how simple this was going to be. But you see, like most others, I was missing parts C and E. I wasn't yet sure how I was going to align certain components of healthcare into a functional archetype. Well, like most things, it took a doctor to figure it out. Once you see how this model works, you'll soon realize that this is how 80% of primary care will be conducted in the next 3 to 5 years. Atlas.md has thought of everything. Here's how it works. But first, a little history. The ACA, aka the Affordable Care Act, i.e. Obamacare, whose official name is the PPACA, or the Patient Protection and Affordable Care Act, law, went into effect March 23, 2010. Now I can sit here until rapture and tell you everything medically, politically, and economically that's wrong with Obamacare, but that's merely complaining. Legitimate as it may be, it does nothing to offer a solution. I've been to town hall meetings with different politicians, and a lot of them have ideas on how to skin it, how to possibly fillet it, and of course the ultimate takedown, kill/repeal it, but none of those will do any good by the time this thing comes crashing down on us, because that takes the enactment of a law. On February 10, 2014, the Washington Examiner had this quote pertaining to Wisconsin Senator Ron Johnson. Quote, "Nevertheless, Democrats will see almost every one of Johnson's proposals as an attempt to destroy Obamacare, to repeal it without literally repealing it. And even if the House passes such a repair bill, Senate Majority Leader Harry Reid would certainly block it." End quote. Gallagher once said, "You have pros and cons, so Congress must be the opposite of progress." Laws take a long time to pass, so just like the movie Independence Day, if you can't beat their defenses, you have to get around them. Ladies and gentlemen, what I'm about to tell you is a loophole within the PPACA itself, which means it can't be blocked. Yes, you heard that correctly. It can't be blocked. I'll repeat that again. It can't be blocked. The exploitation of this rule, which was placed into the bill for this very reason, much like the Second Amendment, much like Article 5, means that try as they may via fiat or executive order, this cannot be blocked. Either way, whether it's slavery, women's suffrage, prohibition, if the resolve of the American people as a whole, as a nation, are such that they stand united in the face of a law that is morally, ethically, and individually unjust, that law ceases to exist, regardless of what is stated on a piece of paper. With that in mind, let's get to the bread and butter and show you how this works. Section 1301A3 of the Affordable Care Act allows for DPC, or direct primary care. What is that? Just what it says. Primary care given to you directly from your doctor without the intervention of a third-party payer, e.g. insurance companies. Now some of you will say, oh, well, we've tried capitation before, or we've tried the free market already and it doesn't work. No, we've tried the free market with a third-party payer before, but that's the Part E that was missing from this A through E equation. Thanks to atlas.md, we've solved that riddle. So how does this system cut costs yet deliver better primary care? It started with the very well-known premise that insurance complicates more things than it helps. So you have to cut the red tape, and the one who cuts the most red tape but retains quality and affordability wins. Take ICD-10 versus ICD-9. More red tape. For those of you wondering, ICD is the International Classification of Diseases, the diagnosis code to which your insurance gets billed from your doctor, to which they determine how to proceed with what they'll cover, or not. So cutting that out entirely, you cut an enormous amount of red tape. Now you only have two players on the field, only two moving parts, the patient and the doctor. You don't have to go through someone else. You can directly call, text, email, or visit with your doctor and know exactly what's going on, and know that there's a personal connection between patient and physician that doesn't currently exist. But in order to have this model work, you have to cut costs, yet you have to retain value. Not only that, you have to save the patient more money than the cost of the membership. Well, how do you do that? One of the starting points was, and this is something common with what software developers have done recently, they take a pain point and work backwards from the customer experience perspective. What are the issues that bother the customer? For starters, it's the limited number of visits, the copays, the cost of procedures, trouble accessing medications and lab tests. So a model was created that offered flat prices based on age only and not medical history, so you're not singled out for pre-existing conditions. This model also offers unlimited home visits, work visits, office visits, and technology visits. They make technology work for you. Now that they're not limited on how insurance companies pay the doctors, they're not limited in how they see their patients. That's a huge value, especially to a busy individual, in order to be able to access their doctor that's much more convenient to their schedule. Harken back to the days of old. Doctors used to make house calls. Doctors got to know their patients, watch their children grow, and even watch the grandchildren grow. This is what doctors went into medicine for, to take care of their patients, not be just another 7-minute appointment that they have to rush through because that's how the system is set up. You can't do that with insurance as the payer. Now you may be thinking, doctors can't do all that. They can't do everything. Doctors are all trained to do the same things. Diagnose conditions, read x-rays, set bones, suture lesions, give injections, lance boils, give exams, comprehend lab results. Heck, all doctors are even trained to deliver babies if necessary. It used to be that you would pay the doctor directly for their services, just like you would a plumber, an electrician, or a landscaper. This keeps costs down because, number one, there is no middleman, and number two, they know that they're getting paid for all the work that they do. This way, they don't have to raise prices on other jobs to cover the cost of the ones they didn't get paid for. That minimizes overhead. Now, don't get me wrong, insurance has its place. Home insurance, car insurance, life insurance, heck, there's even insurance at the blackjack table. But you don't use insurance to buy a roof or gasoline, or if the dealer is showing an 8. No, you use insurance for very specific reasons. As Chris Rock once said, insurance should be called in case stuff happens. Health insurance should be no different. Health insurance used to be, and should still be, used for what I term CCHSS, car wreck, cancer, heart attack, surgery, specialists. Are you thinking it by now? Probably. You're thinking, well, that's all great in theory, Red, but give me some statistics. Give me some numbers I can work with. The way it is set up now, the PPACA has it in the law that insurance companies have to pay 80-20. 80% payout, 20% overhead. For those of you not in business, or for those of you who are young, overhead is the general fixed cost of running a business such as rent, lighting, heating expenses, etc. That which cannot be charged or attributed to the specific product or part of the work operation. For example, buying plastic to make a plastic bottle is an expense. Heating the building is overhead, since the comfort of keeping the workers warm is not actually part of the product itself. So back to the 80-20. 80% of revenue generated from insurance premiums has to go to payouts, and only 20% can go to cover overhead. This is great in theory. The problem arises because 85% of the total overhead costs that insurance companies incur are due to processing the paperwork for things done in primary care physician settings. Yet only 20% of that total 80% payout goes to paying out those PCP claims. Whoa, that's a lot of numbers, I know. Let me see if I can visualize it for you. Let's make the math easy. 100 people have one policy each that they pay $1 per month for. 100 claims at $1 per claim is $100 that the insurance company collects that month in premiums. 80% of that has to be used for payouts that month, so $80 has to be paid out to the doctors. 20% or $20 is what they have to spend on processing those claims. 80% or $80 is spent on payouts. Of that $80 payout, only 20% or $16 is going to pay for the PCP coverage, so $64 is going to cover the costs of CCHSS, things like car wrecks, chemo treatments, knee surgeries, etc., which is what insurance should be paying for. That's not where the big costs come in. That's almost irrelevant for the focus of this model, but just so you're aware of the numbers. So, only 64% of the total revenue of an insurance company goes to things like chemo treatments and hospital stays. What we really need to focus on is that 85% of the $20 that is used to process every claim is spent processing PCP care, things like sore throats and bunions, urinary tract infections, and labs. So $17 of the $20 allocated to processing claims that insurance companies have for overhead is used on PCP care, which, as you remember, is only $16 for that portion of the payout. Only $3 of that $20 is used to process the $64 worth of CCHSS payouts. Cancer, car wrecks, heart attacks, surgeries, specialists. Let's put these numbers together so you can see where the problem is. Can you see it? So insurance companies are spending $17 a month to allocate $16 worth of payouts. So essentially, the process to pay out for PCP costs more than the actual payout for PCP costs. That's like buying $17 worth of dough to sell $16 worth of donuts. I don't know about you, but to me that's pretty ridiculous. But a wrinkle in that fabric is that most insurance companies run an 85% 15% margin instead of the 80% 20% limit allowed by law, so they don't get fined or punished by the government for using more than the 20% of what they take in for overhead. So that squeezes the margin even tighter. This is where the huge costs are incurred. You probably pay less than $100 a month for car insurance, yet you spend hundreds on health insurance. Why? Have you ever argued with your insurance company over what the policy states that they'll pay and what they'll actually pay for? That's why. They have to, by law, watch every penny they take in and spend. So what's their solution to that? You guessed it, charge more money for less coverage. Because in reality, you are paying everything. You're paying the insurance company to cover the cost, and then you still pay the rest, whether it's the deductible or simply paying for what the insurance company didn't. And since the insurance company has now gone the route of covering everything under the sun instead of major medical issues, they have to cover what the doctor or the hospital charges for the overhead, staff, equipment, etc. The doctor merely has to show up and collect a paycheck. Just show up and collect a paycheck? Well, that sounds great to me. Yeah, until you realize that just like most of us with a boss, anytime you have somebody to answer to, that means you don't have the last say in anything that you do. And I'm sorry, but when it comes to my health, my life, there's only one person I want making any medical decisions of mine for me and with me, and that's my doctor. So then how can we fix that? How do the insurance companies save money, which in turn saves us money? For starters, if we eliminate the whole $17 out of the $20 for the allocation of overhead and the $16 worth of payout that's used for PCP coverage, that's 33% they save right off the bat. But also, you see a doctor for a sore throat or a yearly physical much more than you would use it for cancer radiation treatments, hip replacement surgeries, and hospital stays for heart attacks, just like car insurance. That brings the cost down dramatically, so that your catastrophic care that you'd have in your 20s or your comprehensive package that you'd have in your 50s would be dramatically lowered to be on par with car and renter's insurance. Not everybody drives a car, but healthcare is pretty much a guarantee that you will use it sometime. Colds, physicals, monitoring of age-related conditions such as blood sugar, blood pressure, cholesterol, mammograms, prostate exams, osteoporosis, acute conditions like asthma, broken bones, stitches, you name it. So, if it's affordable and everyone has a use for it, you have more people buying affordable policies, which in turn brings the cost down even further. This was the big supposed secret of Obamacare. Make everything affordable and everyone will buy it. Everyone will have coverage and everyone will be just fine. Well, with this model, it can actually happen. Now, as it currently functions, doctors see sometimes 40 to 50 patients a day, and someone at the insurance company has to go through every single one of those charts. Does it meet this requirement? Is this covered? Is this a referral? Is this a network? On average, doctors have around 4,000 patients. 4,000. Why so many? To cover these administrative costs and the cost of the 7 office people to do the things that the doctor would do if they had time, but don't since they're forced to see so many people each day, 9 to 5, Monday through Friday. And they keep those hours because they see so many patients and do so many dictations that they would get burnt out if they worked longer than that. And some of them do. There are some medical school loans that add up to $250,000, and some doctors are throwing in the towel. We can't have the best doctors in the best country with the best medicine in the world walk out because of the hoops that we've built that we make them jump through. The movie Gross Anatomy has the scene where the doctors take their oath and the professor states, "Oh, by the way, the profession that you have just dedicated yourselves to carries the highest rate of alcoholism, drug addiction, divorce, and suicide. Doctors are under enough pressure." Add this to the fact that if a doctor performs a service and the insurance company only pays a certain amount, which leads the patient to pay the rest, which leads the doctor not to get fully paid, or which leads the patient into financial ruin and loss of a lifetime's worth of achieving the American dream, including their house and or life savings, who wins in this? Nobody. This is how people go broke. This is how people lose their homes, their savings. I personally got a bill for $1,550 for 2 vials of blood taken for my wife's thyroid test. I'll show you the bill. I have a picture of it. People shouldn't have to reduce their quality of life to keep on living. Another cost that insurance companies incur, although this is one that they're supposed to, is ER visits and hospital stays. Add that to the cost of processing sore throat claims, and insurance companies are being hit from both sides. Not to mention that a lot of these ER visits are, for the most part, preventable. ER costs are high because of 2 things, aside from the uninsured. Mainly 1, lack of preventative care, or 2, poorly timed illness. If direct primary care can cut into those visits either from dealing with them directly via your primary care physician, i.e. broken bones, stitches, little Johnny's late night strep throat, or by preventing a medical malady in the first place, like going to see your doctor regularly so you can manage your asthma or your blood pressure so you don't wind up in the hospital with a stroke, dramatically reduces ER visits, which in turn reduces the ER's cost to cover the uninsured that they, by law, have to take care of, and in turn lowers the payouts insurance companies have to make, which in turn helps lower the cost of insurance premiums. It's reciprocal. It's completely counterintuitive the way we do it now. Well, that's all fine and good explaining the problems with the system and the savings it would derive, but how do we accomplish this? Well, let's take a look at how the system currently works and compare it to a DPC model. Red, shut up and get to the meat and potatoes of this thing already. In due time, you don't hand your teenager the keys and say, "Start the ignition and drive." No. You have to go through the process to fully understand how the system is different from all the other systems that have been tried, which will allow you to reach the proper conclusion of how superior this model is. Scenario 1. The standard doctor visit. Let's take this one to start off. You make an appointment. For me personally, it takes about 2 weeks lead time to make an appointment at my local clinic of a city that has a population of about 20,000 residents for something as simple as your standard exam, so you can take either an appointment like that or an urgent care appointment, your choice. You show up early if you're a new patient or if you have new insurance from your employer switching yearly, so they can process that card and you pay your copay. My average copay is about $30 for my primary care physician. I am taken by medical staff, usually a medical assistant, to a room where they take my vitals and ask the standard questions. What medications do you take? Do you smoke? Etc. They leave, and after hopefully a few minutes, the doctor comes in and spends about 10 minutes with me and then either sends me to the lab or he sends me with a prescription to deal with that which ails me. I then go to the lab and leave my fluid deposit and or the pharmacy, to which the pharmacy asks for and or processes my insurance, and I pay the copay there, depending on the price of the medication and I go home to await the billing barrage. I will receive a doctor bill of what the insurance company did or didn't cover, if there were any procedures done or materials used in the treatment. Then I will receive a bill for the remainder of the cost of whatever labs were done, and of course I have already paid the pharmacy for the medicine, so that, and I'm probably being generous here, a $30 copay, a $40 prescription copay, and a $30 lab bill. So that's $100 for one visit, with decent insurance. Under DPC, I would make an appointment, see the doctor, no copay because it's all covered under the membership fee, get any labs at cost, and then receive medication at the doctor's office for cost or slightly above. Huh? How? Stay focused. Scenario 2, the broken arm visit. You break your arm. You go to the ER where you have to present your insurance card, and then they process you in the waiting room or the triage room. Then they move you to a room where they take the x-ray of your arm. Read the x-ray, give you the diagnosis, set the bone, pour the cast, give you something for the pain, write you a prescription for the pain, and off you go. You then go to the pharmacy where you have your insurance card processed, you pay your copay, and you head home to await the billing barrage. They bill you for the ER visit, they bill you for the x-ray, they bill you for the cast, they bill you for the medicine, and they bill you for any labs if, for example, this was an injury that occurred at work and you had to take a drug test. All at prices that far exceed that of aspirin or plaster of Paris. I didn't bother to mock up a price for this because it would be too ridiculous, but it would more than likely puncture the ceiling of your deductible. Under DPC, Direct Primary Care, you would call your doctor at any time, he would meet you at the office, take the x-ray, give you the diagnosis, set the bone, pour the cast, give you something for the pain, fill your prescription for the pain right there at the office at cost, plus 10 cents a piece for the pill bottle and the label, and send you home. No copay. And the bill would be for the cost of the x-ray film and plaster of Paris at cost. Whoa, Red, how? Almost done. Allow me to finish. Scenario 3, the heart attack. You would go to the ER with chest pains, probably by an ambulance, which would already have taken your insurance card and information on the way to the hospital of your choice, which you shouldn't ever have to care about or be asked in a situation like that. And you would be rushed into a treatment room, and you would have your insurance cover it, minus your deductible, because that's what insurance is for. DPC wouldn't be involved in this because it is out of the direct primary care realm and where insurance picks up, just like it's supposed to be. And with the cost savings because of direct primary care, it would be at a much cheaper price without worrying about which hospital is in your network. Now imagine Scenario 1 and Scenario 2, the standard doctor visit and the broken arm, taken care of medically the exact same way, but without having to involve insurance. Sound too good to be true? Not anymore. The atlas.md direct primary care model allows for patients to see their doctor anytime, any day, under any circumstances that doesn't require a hospital stay. One reason is that we now have technology that is so advanced that we can bypass a lot of the rigmarole that medicine of the past was forced to conform to while instilling and revitalizing old-fashioned patient care that the physicians of yesteryear enjoyed. The DPC model only alters who you see and where, not the what. So how can you provide that sort of care without incurring costs? Well, the secret is the cutting of the other superfluous costs that allow for the streamlined and efficient care model that DPC provides. Economics is really pretty simple. If what you need costs more than you make, you either make more or spend less. Anyone who says otherwise is selling something. This is how the model is structured financially, and again, I'm going to use simple numbers to make the math easy. Let's say the average family is 2 parents with 2.5 kids. Rounded up, that makes 3 kids. I'm doing it this way because if you could make something financially viable even when you've increased the assumed cost, then it will certainly work when the model is applied in the real world at an actual and reduced cost. And might I add, this model that I'm about to describe is already fully operational and functioning beautifully. No insurance, no government intervention. Per month you charge $60 per adult and $10 for kids 19 and under, which comes to $150 per month for the entire family with no insurance billing. You can visit the doctor whenever you want. No restrictions. If you see the doctor 3 times a year or 3 times in a week, doesn't matter. You're still covered. With this model, the doctor can now drop their patient load from an average of 4,000 patients to around 600 patients. Do the math and you'll be able to see the extra time that the doctor gets with each patient. The doctor can spend 30 to 45 minutes with a patient and never fall behind because of a procedure that takes a little longer, which means you, the patient, are never in an exam room for an hour only to be another 10-minute appointment visit because the doctor is in a rush. Along with the decreased workload, The doctors can now do other things that would otherwise have been done by staff. This enables the doctor to decrease the size of their staff and with that, cut a lot of the costs that drive up prices. With this lowered overhead, the doctor can provide better care, 24-hour care, which even includes house calls for patients such as the elderly. All of this while still being able to comfortably pay the average primary care physician's salary and cover overhead and expenses. And since the doctor is the proprietor of the clinic, any monies that are left over can either be funneled back into the clinic or left in the pocket of the physician. Physicians sacrifice a decade and a half of their lives in order to save and better the lives of their fellow man. The least we can do is make sure that they're adequately compensated for that. Unless, of course, you prefer to keep cranes flying on every hospital in America. Hospitals are nonprofit organizations, so they have to funnel money back into their establishments. This is a side note, but it was pointed out to me a long time ago by an administrator of an HMO, and I want you to start taking notice, especially if you don't believe me. This individual said, take a look. Take a look at any hospital anywhere in America, and if you don't see orange construction cones around it or a crane on top of it, I'll buy you a steak dinner. Now, hospitals could use that money to give each patient a rebate, but another wing makes more money. Not to make this an overbearing political argument, but even if you're part of the 99%, wouldn't you rather have your money wind up in the hands of those that save lives? But I digress, because you may be wondering how one doctor can provide 24-hour care 365 days a year. Work smarter, not harder. Not only does the reduced patient load give the physician more time to do things that all of us need to do in life, whether it's go to the grocery store or spend time with your kids, technology aids in the system as well. There are a great deal of medical conditions that only a doctor can legally assist with, but that a doctor doesn't need to be physically present for. For example, the AMA or the American Medical Association has approved triage for certain diagnoses so that illnesses such as strep throat and urinary tract infections can be done over the phone. If you answer yes to a series of 4 specific questions on a strep throat triage form, there is a 96% chance that your strep throat diagnosis will be correct. Same thing with the UTI, or urinary tract infection. Patients will even be able to purchase certain pieces of equipment that can be used by the doctor via software to communicate medical information encrypted and securely directly to the physician's database. An otoscope that can take pictures of the inner ear, Bluetooth the information to your phone that can then be emailed or texted to your doctor. A medical camera with a light that can take pictures of a sore throat, a bump, a funny-looking mole, an abscess, a cut, an ingrown toenail, a rash, you name it, that can be sent to the doctor for a preliminary diagnosis depending on the particular patient's medical history. At-home sphygmomanometers or blood pressure machines, pulse readers, oxygen monitors, scales, thermometers, blood sugar readings, so many facets of information that can be screened by your doctor without the wandering eye of either the government or an insurance company. There is a great YouTube video dealing with ordering a pizza when people like insurance companies and the government have your medical information. The symptoms of strep and UTI are almost always the same, and there are only about 3 relatively common things that can cause your symptoms. But your physician will have smartphone access to a database with your chart if he or she needs to reference it, and they can make a diagnosis quickly, right then and there. Then, all they have to do is either have you pick up your prescription at the office, or if the doctor doesn't have it, then the doctor can text or email or use specific software to call in your script at the pharmacy, and you could pick up your prescription at any 24-hour pharmacy or hospital pharmacy that they negotiated a price with. Well, what about this pharmacy integration aspect? To be honest, a lot of physicians are reluctant to get into dispensing medication because it seems like something that would be a lot of work. And to be honest, it did seem like a lot of work, but so was making a USB jump drive at one point in time. The first USB jump drive I ever saw was a whopping 256 megabytes and cost about $300. Atlas.md has created a system and software as a solution that practically does the work for them. 44 states allow doctors to dispense medication directly from their offices. Rest assured that when this takes off, that number will reach 50 pretty quickly. Now, the caveat to that is that the doctor can only dispense the medications to his or her patients and not just any Joe Schmo off the street. Also, the doctor will generally carry more common medications but won't necessarily have everything in stock, which will still make your typical pharmacy viable. But the doctors can get these medications wholesale from a dispensary. Even if the doctor were to mark up a 2-cent pill by 100% and charge 10 cents a piece for the prescription bottle and the prescription label, that means the doctors cover their costs and saves you untold amounts of money. If the standard retail cost of a pill is $4 a pill for 3 times a day at 30 days, that's $360. Say your insurance makes you pay 10%. That's $36. With DPC, you're paying 4 cents per pill at 3 times a day for 30 days. That's $3.60. Your insurance just saved $324, and you just saved 1,000% on your prescription and 10,000% if you had to pay full price. Meanwhile, the doctor made a whole $1.80. Those nasty money grubbers charging me 100% markup. Blasphemy, I tell you. Now you can justify a membership price because the doctor is bringing so much value to the patient. You're saving them so much more than they're spending. We want to be bold enough to say that good doctor-patient advocacy now means embracing sound business principles that says we're going to do good medicine and good business and make the two blend in such a way that embraces and yields healthier patients, which in turn begets happier patients by giving them access to highly affordable wholesale medication and lab tests for a 95% savings. Now they have very little risk in getting not only necessary and adequate, but extra health care, meds, and labs that need to get done in order for them to completely manage their conditions. Even more important, now they need less insurance. Now you don't need to spend $800 a month on insurance to cover a $3 thyroid test. The same principle used for wholesale pharmacy can be used for labs as well. If the doctor doesn't have a lab, then they can utilize local labs and even national labs when this thing takes off. The doctor can even dispatch a mobile lab if necessary for patients who need it if they have difficulty moving. Just another one of the many ways this saves you money. Aw, come on, Red. There's plenty of other things that medical professionals need to have access to in order to serve all of the other aspects of healthcare. Like, scans. What about scans? Well, most clinics have an x-ray machine, but imaging capabilities of an orthopedic office, for example, can be utilized for scans. Anytime a machine sits idle, it's not generating revenue. We all know that bulk items are cheaper. Well, use the same principle for scans. The more business a location with the equipment gets, the more it enables them to lower their prices. You can get simple plain film of joints and extremities for $25 to $30 with a read as an out-of-pocket expense. There is a hospital in Oklahoma that is offering MRIs for $299 cash price upfront and will give the patient a $25 gas gift card if they're traveling more than 50 miles. The market responds to the need of the consumer. What about other services? Like I said, doctors are trained to do every standard procedure. Physicals, laceration repairs, biopsies, ultrasounds, injections, EKGs, spirometers, audiometry, urinalysis, cryotherapy, lesion removals, bone settings. Those are all very affordable for doctors to do for their patients in office, thus making it an incredibly high value. What about the cost of those services? EKG pads are about 3.5 cents per pad. The clinic can absorb that into the cost of doing business. Same thing with equipment such as gauze, cotton balls, iodine, tongue depressors, swabs, rubber gloves, rubbing alcohol, stethoscopes, thermometers, posters, magazines, you name it. These are all things that a clinic needs, but once again, you buy in bulk, you save money. Well, how do doctors handle vacations? Doctors always have other doctors they trust, so in emergency situations, another doctor can have access to the same patient database because generally doctors will team up in pairs or groups of 3 to 5 in one clinic, so you are never without quality care. And that's even assuming you won't be able to reach your doctor by phone, text, email, or even social media. Having that 24-hour access is one of the great and unique features of this healthcare model. If you're a physician listening to this and you're burnt out, tired of what you're doing, or looking for a different option, for those doctors who think this can't be done because they'd have to start from scratch, atlas.md has software that basically runs your clinic for you. Scheduling, billing, medical records, labs, shipping, dispensing medications, annotating without ICD codes, dictation, imaging, insurance, clinic models, you name it, it's there. There's no need to reinvent the wheel when the best one on the market is available to you. They've mapped out that whole process for you. This direct primary care model works wonderfully with small businesses where one clinic handles all the patients from one particular company. That could even be an affordable perk that the business provides to its employees. The employer pays for half or all of the cost of the DPC membership, or perhaps the employer is kicking for the actual health insurance and the employee pays for the DPC membership, or vice versa. Getting together with other doctors and starting these clinics with small local businesses as your main or starting patient pool is a great way to start your own DPC atlas.md clinic model. And the best part about all this is it works with Medicaid and Medicare. Medicaid and Medicare can now be used for its intended purpose, large out-of-pocket expenses. You can even have it set up to where the monthly membership fee of your chosen, I repeat, chosen clinic can be deducted automatically from your Social Security check, leaving senior citizens free to visit their physician whenever they need to. There are many patients on Medicaid and Medicare, but some are having trouble finding a doctor who takes Medicaid and Medicare. This eliminates the need for worry about what will be covered because the cost will decrease so dramatically that the large cost expenses are now able to be covered by Medicaid and Medicare. Can you say budget deficit solution? On top of that, you can still have HSAs and FSAs that can be used for the deductibles in your catastrophic or comprehensive insurance plan that you can choose with your insurance company. Much like buying a PC or a pizza or even a sandwich at certain convenience stores, you can pick and choose the best option for you and your family a la carte. Just like a gaming computer, you might not need a fast processor, but it might need a lot of RAM and a good video card, only a medium-sized monitor, and no special keyboard or mouse. You can purchase that combo and get the exact PC that fits your needs. Say you like your pizza with a lot of meat and no vegetables, but you still want mushrooms. Now you can have it. Same thing with health insurance. A single male of 27 has no need for birth control coverage, nor does a 50-year-old woman. But yet that same woman might need a bit more hospital protection in case she needs to be hospitalized for a possible heart attack if that sort of thing runs in her family, or a broken hip due to osteoporosis with replacement surgery like her mother and grandmother had. The 27-year-old man might need a very small plan in case he tears a ligament playing league softball and needs surgery, or in the rare chance that he might get diagnosed with cancer, just so he doesn't lose his home to medical bills. The beauty of this model is that both patients have the ability to see their primary care physician first for any medical malady without having to kick in towards the deductible, whether it's rare types of scenarios, blood pressure and cholesterol management, or a case of the sniffles. Insurance can be used for either acute, life-threatening emergencies or chronic illnesses and injuries that may happen. The McCarran-Ferguson Act of 1945 is the act that prevents insurance companies from being purchased over state lines. With this new DPC model, this may have a chance of being readdressed if the state and federal legislators can create a working environment that is symbiotically beneficial for all involved. Not only do you now have a legitimate solution to Obamacare, you have a means to reform the entire healthcare system regardless of lobbyists, big medicine, and big pharma. Yet everyone still makes money, but saves exponentially. The patients save money on their healthcare costs, the doctors save money on the cost of running the clinic, the insurance companies save money on overhead, the hospitals save money by not having to cover the uninsured, the ER save money from not having to deal with acute situations that can be prevented if patients have access to affordable primary care. All of this money that is saved will go into the pockets of every consumer and every business. Imagine the economic boom we could have with all of this extra money. We could have an economic rally that Reagan would be proud of. It's reciprocal. Not to mention some, not all, of the reasons that companies move businesses overseas is that they don't have to pay the tremendous healthcare costs or taxes that go to those healthcare costs here in the United States. There's a reason that there are laws on the books to why people who reside in one state can't go to another state to purchase a vehicle in order to save money on the taxes. That law is there for a reason, as are coupons. People like to save money. Regulations and taxes matter. And a good portion of these taxes are collected to spend on what? People. People who need that money to cover their healthcare costs. That is the vicious cycle of healthcare spending we currently have to deal with. If we cut that gigantic cost out of a business's operational budget, then businesses would be far more likely to move back here since it would enable them to keep jobs here and do so without destroying employee morale due to the healthcare costs that are currently constraining both businesses and employees. Then, businesses can reinvest those extra savings and continue bringing even more jobs back to America. Different topic, but it does deserve mention. This model, DPC, Direct Primary Care, it doesn't require a law. In fact, it doesn't require us to change anything other than our way of thinking. Can you see it now? You no longer need to insure family medicine. High value, low cost. All bases covered. You need to educate yourself and inform others of this system. If you're able to remove all the cost and burden of red tape that falls under the umbrella of direct primary care from the insurance companies and on to the physicians who should be performing these services to begin with, you can really make a paradigm shift in medicine. All of the quote-unquote healthcare reform, as counterintuitive as that phrase is, that's coming down the pipe is making physicians' jobs more difficult. There are clinics in Utah whose office managers have run the books and say that without a doubt, when ICD-10 hits on October 1st, they'll have to close their doors. They can't afford to stay open. So in a way, the beauty of this is that these clinics either have to close their doors or switch to the direct primary care model by default. But why go through the pain and misery of drowning when there's a life jacket within arm's reach? You can't tell me that President Obama himself is not going to need to see a doctor when he gets an earful of this. Of course, this statute is in the bill, and he should know what's in it, now that it's been passed. This model sells itself. Change will not come from the top down. It will not come from government. It will come from the bottom up. Grassroots. Patients and doctors who are fed up with the current system of everyone but themselves controlling literally their own lives. That's not the way it should be. It's your life, your doctor, your decision. Please share this and help spread the word. Government makes no money with this system. Government has no control over this system. But mark my words, Obamacare was passed. They will find some way to get their grubby little hands on your body. Don't let them. This is the only government in human history that is of the people, by the people, and for the people. And we live in the age of information. Keep yourselves informed. Do the research on your elected officials and where they stand in regards to their control over your health. Join the fight, sign a pledge, help elect people like myself who want government out of our healthcare system. We now have a solution. Let's use it to fix this problem. Go to www.voteredarnold.com and sign this pledge to get this direct primary care system into the minds of the American public and off the ground. I will keep the website updated on public officials who sign this pledge so you know who to vote for in your local community regarding this issue. Information is free, but campaigns cost money. Please donate to the Vote Red Arnold campaign or visit atlas.md at atlas.md to help Dr. Josh and I move this idea forward. The Good Doctor does free consultations to any doctor looking into adopting the Atlas.md direct primary care model. It took every voice in America to enact prohibition, but it also took every voice in America, and a Great Depression, to end it. Let's change America together, shall we? But let's skip the Depression part this time. Talk to your friends, talk to your family, talk to your neighbors, talk to your coworkers. Write your congressional representatives and your senators. Call your state legislators. Ask your doctors if they've heard about this, and if not, direct them to watch or listen to this on their next lunch hour or on their way home from work. Nothing changes if nothing changes. We have the power, we have the technology, we can make a difference. Remember, it's your life and your health. After all, if you haven't got your health, you haven't got anything.